Right,
So
right.
you might look into
I'm a
that.
perpetual student, so I'm trying to decide what to do to get me off away from cots,
Praise
Away
be.
from what?
away from the cots.
Just the
Like
sun.
I don't want to do patient. Like
Yeah.
I want to
I
like
just put on
move
it
on
because
from
it's
this before
what you want.
it breaks
I
me.
just put on it refresher.
My body, that is. It won't break this. That's completely hardened, but I want to. I'm thinking about PA school, so sounds terrible. I don't even have an associate, so I have to start from the bottom. All right, folks.
We had one right at our house as well.
Stupid wheel.
It died over Morgantown.
That's what I heard.
Are you ready? Want to learn about diabetes? Sure. Does that sound fun? Are you diabetic? No? It's not just all old fat people. Kids get it too.
Type 1 diabetes.
We're going to talk about that in a minute. Stay tuned. All right. The champion of diabetes, huh?
I thought that was art.
Yeah. The champion of diabetes.
You're good.
All right.
Can we kill the lights though? You can't see.
Like all of them?
Yep.
Okay.
That is the opposite.
There. Yes. That better?
Yes, sir.
Right on. Diabetes for EMS. You know, usually we look at diabetes as a fairly straightforward thing for us on the typical, right? Like especially if their heart rate's 140 and they're breathing.
That.
Well, that's fun. They're breathing.
If that continues, we'll have to go to the other end.
Well,
It's going to continue with their firefighters.
like they know, right? Like
They know that we're down here?
Yeah.
They should.
Yeah, they know.
Can't
They
make
don't,
them
they don't care.
I love that. So, love that for us. You know, until they're breathing 34 times a minute irregular, they're not responsive, right? Then the diabetic becomes more than just give them some D10 or D50 and move on, right? It's a little more complex. Click, click. Click. Gotcha. What is diabetes? We've got a couple different types that we see on the irregular. Type 1, autoimmune attack, destroys your ability to create insulin. Okay. When do we start seeing this? Almost always, unless there's some kind of a cancer involved. When do we start seeing this?
Teenagers. Show them what that.
What?
Autoimmune.
The type 1 diabetics.
Usually childhood.
Usually childhood, right?
I said teenagers.
Oh, I'm sorry. I thought you said
I said
20s. I'm sorry.
teens. know-
I can't hear
teenagers
anything.
have-
Teenagers. This can pop up as early as 4 to 6 years old. Okay. You'll have that call where there's maybe a kindergarten age kid that you get to them, they're listless, they're pale, their skin is just super dry, like flaking dry. They're not responding to you right. They're not afraid of you. Like that's a huge, right? Like when you walk up to a kid in a house and they're not afraid. That's a red flag for me. Like I want to see them like, like mom, like, like what's going on, or dad, whatever, Meemaw. And they're just, and they just look puny. They act puny. They're not acting right. You could be the first contact for that kid's diabetes. They don't know they have a problem. What's wrong? Does little Timmy have any medical problems? No, nothing. Okay, well, we do now. So you take that blood sugar and it's, just get a high on your glucometer, right? We've got a problem. It can pop up later, your people receiving some type of chemo, radiation or something, pancreatic cancer and things that can zap the body's ability to create insulin. A little bit different problem. Same but different, right? So type 2 is a development of insulin resistance. This is what we usually see, okay? These people are on what kind of medications? They can be on insulins, metformins, things like that. The body still is able to produce insulin. It's just not very good at making it and or using it. Okay, you get gestational diabetes, which is almost always diet controlled, pancreatic issues, other conditions, that are rare. Okay, diabetes, sugars, diabetes, hand in hand, always. We see it constantly. 37 million Americans, I thought that was a profound number, are affected by it daily, and it keeps getting bigger. Because why? Because we like to eat. Some people are going to get it. Some people are going to be type 1 diabetics. It's going to pop up somewhere in their childhood to mid-teens to 20s, and it's going to happen. The rest of us really like getting that monster burger, right? Like, it's so good, and we just want to eat, and then we get big, and then our body's like, man, I'm just not going to use your sugar anymore because I don't want to, and then so c'est la vie. So either way, us being able to recognize and appropriately treat a diabetic saves lives. Well, that's a lot, isn't it? Has anybody ever seen like a graphic like this before of how the body pulls glucose into the cell? Insulin receptor does things, that pops up because that's not always there, right? It's kind of just hanging out in the cell. That tells that to go there, and then glucose gets pulled through. Very, very, very basic. You've got potassium that's involved and all that good stuff, and but that is to the simplest functions. That's how it works. So if that stops reading that and telling that to do that, then we see our diabetics, our type 2s pop up, right? Hypoglycemia. When does this happen? When do we run on the hypoglycemic the most?
When they take insulin and don't eat.
Mm-hmm.
Or when they take too much insulin.
Or they take too much insulin. In my career so far, I have seen this the most first thing in the morning. They didn't eat a big enough dinner, took the normal dose of insulin right before bed, laid there in their own sweat all night. Significant other wakes up, it's like, oh no. And now we're there waking them up, hopefully. Their bed is just completely soaked in sweat, and they're not in a bad way. I feel like sometimes our non-compliant diabetics literally keep us in a job. People who don't follow their sliding scales, who administer their insulin without eating, who, and maybe it's a socioeconomic thing. Maybe they don't have enough money to buy food and stuff like that. That's an issue. It's a social problem. But what do we do about it in the now? We do that, right? We all know how to treat the diabetes, the oral glucose, the D10s, the D50s, all of that stuff. What is your practice? D10 or D50? D50, right on. I don't know, there's a lot of noise out there that, D50 is archaic, we shouldn't be using anymore, but honestly, if you are good enough at IVs, as long as your IVs are good, it's safe. It will not swing any faster or slower than D10 does. Pharmacology moment. How much glucose is in a 250 ml bag of D10?
5 grams.
25 grams. How much glucose is in a bag of 100 ml bag of D10?
10 grams.
How about a liter? Why is it important to know that stuff?
Know how much you're giving.
Because you need to know how much you're giving. Exactly right. So if I run on a patient and their sugar is 45 and I want to give 10 grams of dextrose out of a 250 bag of D10, how much am I giving?
100
100 mLs. All right. Is it 25, 10 grams, 2.5? Is it quite 100? Do math. Do math. Use. Are we disinterested?
Sorry, I missed that.
If I want to give 10 grams of dextrose, let's make it easier. Let's say 12 and a half grams of dextrose out of a 250 bag of D10. White shirt doesn't answer. He's answered all of them so far. What's your name, buddy? Andrew doesn't answer. Okay. 12 and a half grams of D10 out of a 250 bag. How much am I giving?
All of it, right?
Mm-mm.
No?
How much dextrose is in a 250 bag of D10? 25
I'm
grams.
sorry.
Right. So we want to give 125. Right. Right.
I was thinking
I think it is 100 then. It is. Yeah, it is. I'm sorry, my brain just wasn't braining. I'm not afraid to admit that. I don't mind it at all. That's honestly like being on the helicopter versus being on the ground. I love it so much because there's such a good checks and balances there. Because hopefully you're both good at your job, you know, and we can check each other, and I love that so much. So yeah, so we're gonna give 12 and a half. We're gonna get 125 ml, 100 if we want to give 10 grams, right? It's important because who knows what pharmacy is going to supply you with that day and what you get on your D10. D50, what's your protocol for that? How much do you give when the blood sugar is below what threshold? How much D50 do you give to somebody with a blood glucose of 40? All of it? It's all right. How much sugar is that? 25 grams, right? And then what do you do? Yeah, yeah. Who here is good at cooking? Do we make meals?
cooking.
Do we make meals for our diabetics after we wake them up? Yeah. Why do we do that?
It's only, D50's only gonna last for so long.
Yeah. It's not going to last very long.
Some
D10's the
proteins.
same way.
Gotta
Some
have some bread and
peanut butter jelly
peanut
sandwich. I've
butter,
cooked whole meals. Like if I like them, I mean, we're gonna sit down and have breakfast. Honey, I've been running all night long. I'm tired. We're gonna have breakfast. Okay. You know, I don't mind. Eggs. You got any bacon? Yeah, cool. They're not awake. They don't know what you're cooking. They're gonna wake up to a 3-course meal. You know, like man, the other truck's running their butts off right now, aren't they? You know, whatever. Cook them some food. High protein, peanut butter, maybe a little bit of jelly on there just to help with the palate. Give them some milk, you know. Give them something to, or you're going to be there again. And how long? What, 30, 45 minutes, an hour, you're going to be back. So cook a meal. All right. So that's the low. And we know the signs of this, right? What are they?
altered mental status.
Sweating, fast heart rate.
Yeah, pretty easy stuff, right? This is the bread and butter of EMS. Like we do this so much. I'd say if you've been a medic for any amount of time, you can do a diabetic wake up in your sleep. What about, and this is one that humbled me personally several years ago. Do diabetics always drop their sugar in the middle of the night at their house?
No.
No. When else do we see it?
I've seen it in a parking lot at the grocery store.
Car crashes?
Car crashes, yeah.
I had a gal who was a known IV drug user also, who also happened to be a diabetic. And she caught me off guard one day. I thought, there's no doubt about it. This is an overdose. I tunnel visioned in on it. And somebody's like, all right. Oh, we found a glucometer in the car. Like, oh no. After it's been a long day, whatever, you give them the third degree. I'm not afraid to admit that I've been there too, and crap. So always keep it at the forefront of your mind. I have seen a trend lately that, and it's like the who hurt you, because like, why are you doing blood glucose on every single human that you encounter? But you've probably been caught in a situation where you forgot to check it on a car wreck or something like that, and you got caught with your pants down. But that's the symptoms and signs that we're looking for. And honestly, if I'm not seeing that stuff, or the other side of it, very dry, then I'm probably not routinely checking a blood sugar. But if you're seeing this stuff, check that blood sugar. Does it hurt to check a blood sugar on everybody? No, it doesn't hurt. If you've got a few minutes, if you've got somebody that you don't suspect it and they're gomering on you, are you going to waste time with it? I'm not going to, unless I know that there's something else there that I need to be watching for. But it's for idle hands if you don't have something to raise your suspicion. DKA versus HHS. I know it's on the board. In your own words, what's the difference? I took it away from you.
Type 1 versus type 2.
DKA versus HHS. Yes, type 1 versus type 2. Which and which?
DKA is usually type 1.
Yes. HHS is usually, is that standard across the board? This is gospel. If you're type 2, you can't go into DKA. No, we know that's not true. Type 1s will typically not go into HHS though, typically. But your type 2s can also go into DKA. All right.
Simple, and I never really realized that.
Yeah. So to get to the meat and potatoes of the difference between DKA and HHS really comes down to the last letter in DKA. What is it? Acidosis, right? They're going to present in a very similar fashion, okay? The difference is who's presenting, type 1 versus type 2, and are they in an acidotic state, okay? How are you going to tell the difference? The paramedic, an EMT, double paramedic in the field. How fast they're breathing. What do we have? End tidal. That's going to clue us in to whether we have an acidotic state going on. We have end tidal. What are we going to see on this end tidal? You raised your hand and you said end tidal. Now you got to give me the rest of it. What are we going to see? What are we going to see with our DKAs, our acidosis?
Is it the shark fin?
That is bronchospasms, right? Let's narrow it down. Is their CO2 going to be high, or is their CO2 going to be low?
It's going to be high. Or
Low. Their CO2 is going to be low. Why is their CO2 going to be low? They're hyperventilating. Why are they hyperventilating? To blow off ketones, to blow off CO2, to buffer our acidosis, right? What is our body's first response to buffering, second response to buffering acidosis? Respiratory. First, they're going to start peeing. Second, their respiratory rate is going to increase. So, otherwise, these two are the same. They look the same. They sound the same. It's tough to tell in the field whether you have DKA or HHS. It must be getting close to 11. Is that the way it is here? Like you usually have like a lull before 11 and then
the witching hour.
The witching hour, right? Right at lunchtime. Yeah. So, Another key factors, how long is it taking for this to develop? DKA is usually a little slower. HHS is even slower. Okay? Which is more dangerous?
DKA.
Why? Is that acidosis? The acidosis affects so much, right? You're not just dealing with a dehydration issue. Dehydration is definitely a part of it, but it's not just one or the other. Okay. So this is going to be treatment. DKA, fluid resuscitation. Transport. Who can handle a DKA in an HSA patient?
A paramedic.
And a paramedic. Literally anybody from our level, anybody from an advanced EMT up can adequately take care of a DKA or an HHS patient. Eventually they need insulin. In the short term, what do they need? Fluids. They need fluids. What kind of fluids do they need? What kind of fluids do they not need? Do we want to give them a fairly isotonic fluid that's not battery acid? What do they need? LR. Why do they need LR? Because they're acidotic. Okay? LR has what in it? What does LR have in it? Potassium. Sodium bicarb. Right? What else does it have in it? I think a little bit. So it has a balanced set of electrolytes that these people are going to have a deficit of, right? So let's back up. As the insulin binds, goes through the shell, goes through the cell, and then we start giving them glucose. What does this require for the glucose to go into the cell? What does that need? It needs potassium, all right? So as the body is working its little tail off to kill itself, basically, as the body thinks it's doing a really good job at this and it's doing terrible, our potassium is going down. And then when we start giving insulin, what is it going to be doing even worse? So you're going to keep driving that potassium down, right? What does LR do? If it's low, what does LR do? Brings it up. If it's high, what does LR do? Brings it down, because it's a gradient and not an additive, right? So we want to give fluid resuscitation. The best fluid to give would be LR. If you don't have LR, battery acid will do. What's the pH of normal saline? No. The pH of normal saline is 5.5. You know what the pH of sulfuric acid, that's what's in batteries, right? Yeah. No. Hydrochloric acid. The pH of hydrochloric acid is 5. Fun, huh? Yeah, dogma. You gotta love it. So we're going to resuscitate with whatever we have available, and if you can get your hands on LR, give LR. Are we going to just slam 3 liters into this person as hard as we can? No. Why? It's wackadoo, right? Like, that's bad. No one needs that. Ever does anyone need that. We're going to do controlled boluses. We're not going to just dump for the sake of dumping. We're going to do controlled boluses, and we're going to manage the patient in that manner. Insulin therapy. You are in the hospital now, you're a medic working in the ER, and you get an order for insulin. and you start to drip with the nurse because we're not capable, apparently, of doing that. And your patient who came in with a blood glucose of 657 an hour later has a blood glucose of 400. Are we good or are we bad? It's too quick. Yeah. You were grimacing at me. Why is it too quick? Are you a nurse too?
No.
No. Okay.
She wanted to be.
So, I almost did. I'm glad I didn't. I don't think I want to do bedside stuff. Anyway, that's whatever. That's too fast. Why is that too fast? What can happen? Probably not. Probably not. If we drop the sugar too fast, what can happen? Demyelination? No, okay. All right, gotcha. Oh, man. Let's see. Let's find a graphic for you. I'll have to add that. Can't find one. Okay, if you lower the sugar too fast in your brain, the myelin sheath, you know what that is? If you lower the blood sugar too fast, it'll separate. It's bad. So don't do that. We want to bring it down slow. Okay? It took days and weeks to get them there. We want to take days to week to bring them back down because bad things happen. Sodium shifts, stuff goes crazy. Okay? So while we are lowering their blood sugar, we want to see about 100 per hour. Okay? And we want to close the gap. What does that mean? I'm going to rack your ability to remember acid base today on this lecture. It's important. You got to know acid base. It's important, especially if you have any desire to do critical care in your future. Okay? Have you ever heard of the anion gap? Right? We know it exists. And that is a balance of the relationship of sodium, potassium, chloride, ketones, and a whole bunch of other stuff, right? And that number, as we measure it, the higher that gap gets, the worse our acidosis is. And there's some types of acidosis that shows a gap, and there's some types of acidosis that don't. Remember mud piles? Ever heard mud piles? Okay. Methyl alcohol, uremic acid, right? So we want to close the gap. So we want to lower the blood sugar, shed ketones, correct acidosis until that gap gets closer, but we want to do it slowly until the sugar gets down, and we want to monitor the pH, the sodium bicarb, and we want to monitor renal function. Okay? As the gap gets lower, as the blood sugar gets down to around 200, you want to hear something anomalous that we do? And then I'll move on, because this is beyond what we do in the 911 space. What do we do as their blood sugar approaches 200 and we're still in an acidosis state? What do we start? Sugar. We put them on a D5 drip, so that we can keep the sodium and the potassium balance and the insulin going and keep giving them fluids, but we don't want to drop the sugar too low, so we give them sugar and then we balance them out and let their body achieve homeostasis on its own, right? Okay, Acid balance, acid base is so important with managing these people. And in a little bit, we're going to get to why and how we manage acid base on these people. Okay? HHS, fluid airway support, rapid transport. That's it. There's no acidosis. Their sugars are greater than 1,000. Stupid, crazy high.
Now with HHS, would we be going with sodium chloride instead of LR in that situation since they're not acid?
Man, I really just love LR. I really just like LR. I don't think, I haven't seen any studies to prove the benefit of one or over the other, but I really just love LR for everything, because everything's a gradient. It's not additive. It's not like giving the mill equivalents of potassium. So normal range, 70 to 140. Use the glucometer carefully. Just use it. Use it. You want to make sure you clean the finger. You know, if somebody's been eating jelly donuts or something like that, will it alter your readings? It should. I mean, scientifically it says you should. So clean hands save lives. Click. Oh, that's a lot, right? Why is it important for us to know about these different insulins? Oh, there's stuff underneath that. Boo.
What'd you do to your slides?
Well, there is. Diabetes. Okay. All right. So we've got different insulin types that people are taking, right? We've got different, you got short acting, intermediate acting, and long acting. Why is it important for us as EMS providers to know the brands, the types, and know what these people are taking?
Because I can't tell you the amount of times I've had somebody take what should have been a rapid and it was actually a long acting and they took the wrong dose. So you need to know because you can't just leave them.
If you pick somebody up and they have taken a long acting, they've taken, let's say, Lantus. They've taken Lantus. It's a really common insulin we see, right? We see Lantus all the time. And they're supposed to take, I'm just going to throw a number out here. They're supposed to take 10 units. I don't really know what the dosing usually is on this. They're supposed to take 10 units. You look on the bottle, it says take 10 units every night at 8 p.m. But they took 30 because they thought it was their fast acting. Is that a person we can get a refusal on after we wake them up?
God,
No. If you don't even look at their medications or ask these questions, how easy would it be for you to just do that? We get complacent. We don't think about it. It's the middle of the night, man. We're getting hammered. You know, how easy is it to forget to find out why did this thing that we're here for happen? It's really easy to do. There's people that have done it, and there's people that are gonna do it, and that's it. It's really easy to do. So what we do good assessments, we do good patient history, and we find out that we took a ton of Lantus, and we can't leave that person there anymore. Even if that means you've got to sit there until that person comes unresponsive again, and then you take them to the hospital and wake them up on the way. We all know the games. We all know the tricks that we do to get people the care that they may not even want, right? Don't leave these people at home. Be good clinicians. Take care of your people. I'll have to fix this later. Like I said, this is the first time I've presented this. So, and then you've got your hypoglycemias and things of that nature. The way this is supposed to work is when I first come into the slide, that is hidden. And then I click the button again, and that pops up, and we talk about that, right? Here we go. So it's important on your samples to get this information, figure out what these people have taken. If they don't know, you need to try to get them to go to the hospital. You need to do everything you can to talk them into going to the hospital. Okay? Peds. They're going to burn through the sugar faster, right, on a normal situation. They may not have a diagnosis of diabetes yet. They may not have, given, the socioeconomics of some of the areas in southern Indiana that we care for, they may not know anything about juvenile diabetes. The parents may not know anything about it. The family may not know anything about it because it's just the way that some of these areas that we take care of are. They just don't know. So we may be the only person in between them and the hospital to get them there, to get them taken care of, right? Geriatrics, polypharm, right? We talked about this in the last lecture. How often does polypharm play into our diabetes? All the time, right? Alcohol-related hypoglycemia. Do you carry thiamine? Don't carry thiamine?
They took it off a while back.
We still carried it in Greensburg, but I never gave it. In 16 years, I never gave it. So it's not something you see often. It's really tricky to diagnose. It kind of depends on when you catch your dirty 30 drinkers a day, when you catch them throughout the day. I lied to you. I gave it one time. We had a guy who regular 2-3 times a day, some days, and his welfare check was coming 2 days, and he was out of money. And so he didn't have any beer. So we're detoxing, right? We're seizing and kind of, you know what I mean. But we're having tremors. How about that? We're having tremors, and his sugar is in the tank, right? Because he's not drinking. So he's getting no nutrients now, none, because he's not eating, because they're not even thinking about that because they're in DTs, right? So he got thiamine along with the sugars and stuff because they need it to be able to metabolize it. Sepsis. My goodness. Let's talk about sepsis with DKA. You've got a patient that's been having trouble breathing for 4 days. Productive cough, rapid heart rate, low blood pressure. You take a blood sugar and it's 275. Why? Why? Because you could look at that glucose at 275 and be like, oh, this is DKA. Can you have sepsis and DKA at the same time? Yeah, you could. What is that glucose likely related to? Is it a diabetes problem? Or is it a stress response of the body problem? I think in that situation it's a stress response. So be careful about how we treat our patients that we're watching for mimics of. Now, in the case of sepsis and DKA, the treatment modality is going to be pretty similar as long as you are confident that this is an infectious process and not CHF or something like that, which in my opinion, one of the hardest things to diagnose that we treat often is differentiating CHF and pneumonia. Right? Because if you treat CHF like pneumonia, you're going to have problems. And if you treat pneumonia like CHF, you're going to have problems, right? So you just have to be careful. And it goes back to, hey, don't just stand there, do something. Or don't just do something, stand there. Maybe we don't have all the information we need to take care of this person right now because they're extremely complex, they're polypharm. Maybe it's DKA, maybe it's sepsis, maybe it's CHF. They're presenting the same right now. We don't really know. They need scans, and we need to know exactly what's going on before we start throwing fluids or furosemide or nitros. All the things that we do for all of these. So supportive care, right? ABCs, and go to secretions. What did I say about that? Yeah. Do we need to intubate this person?
No.
No. Why would we? I don't know. I'm going to another round that one. All right.
Because we can?
Yes. No. I'm not going to. We're going to throw up all over the place. Words are non-recognizable, known to be on insulin, but didn't feel well at breakfast, so they didn't eat. But I bet you they did take their insulin, because my doctor said I gotta take it 2 times a day. What do? Dextrose. Why do we do it? Because they need it. Patient slowly comes around, thanks a nice ambulance drivers for their service.
Very specific.
Now what do? Yes, we're going to test your colon area fillings. Will a PBJ work fine?
Yeah.
Yeah. Some complex carbs, a little bit of protein. If you're getting smoked, make them smokeless. All right. If the cockroaches are crawling across the countertop, get out of there as fast as possible. All right. Do what? Did a specific patient come to mind?
She said this stuff would be hitting us up, what are you doing?
What are
I
you
said,
doing?
your responses.
That's right.
Still working on the patient.
Still working the patient.
10 seconds with breakfast.
No, we don't say that, we're still working on the
Still working on the patient. When you start cooking breakfast, see, you gotta stay in front of them. When you start cooking breakfast, information around the delay on scene for patient care. Covered. What are you gonna say to that? You might get an email about it later, but we've all been chewed out before, right? 24-year-old female, type 1 diabetic. What do our type 1s do? HHS or TKA? DKA. Altered mental status. Kussmaul respirations. Who in this room can tell me the difference between Kussmaul and Cheyenne-Stokes on a patient 100% of the time? I can't do it. Irregular, rapid respirations, right? Clue you in that something's going on.
Shane Stokes has moments of apnea though with it, isn't it?
They can.
Yeah.
They can. They can. But 911 Justin, it's irregular or something wrong. Let's figure out what it is. Blood glucose is 468.
That sucks.
That sucks. That's no good. At least it doesn't say hi.
This is true.
It doesn't say high. So we're type 1. Our glucose is less than 1,000. So we're probably not in HHS. We put them on N-tidal, and her CO2 is, say 22. Why is that significant? Respirations are very rapid, like 36 in a regular.
Because we're blowing off too
We're
much.
blowing off a bunch of CO2. Now, you say too much.
Oh no, not enough. We're not blowing off enough yet.
Sorry.
You say too much, but is it too much? I haven't picked on you yet. But on this one.
You've been picking on.
Not on this one, just on the last one.
Oh.
So when we say not enough versus too much, who is better at blowing off CO2 to manage their acidosis? Us with a ventilator or a patient with the respiratory drive?
Respiratory drive.
Respiratory drive, right? We had an in-depth conversation about that in that airway class that I came to with you, right? So these people, we're not giving this person sugar, are we? No.
Oh, no, we
No. This is not the typical diabetic that we go on. This is truly an emergency, folks. Is this person going to die in 20 minutes?
No.
No. Is this person going to die in 2 hours?
No.
Probably not. Probably not. Is this person going to lose their respiratory drive and aspirate in the next 5 minutes with me sitting right next to them?
No.
Probably not. Probably not. This person, if they're unresponsive, do we need to RSI this person? No. Let's get in that mindset. Hopefully within the next year, you guys are going to be doing RSI, right? That's the goal. So do we need to RSI this person? Why is this person the single-handed most dangerous intubation you will ever perform? There is no other RSI that you're going to perform in your careers than the metabolic acidosis. Why? You already know the answer, so you're not allowed to answer. We talked about this in the airway class the other night. Why is this the most dangerous person you're going to ever RSI? Metabolic acidosis. I guarantee you she's got a wide gap, probably greater than 20, maybe even pushing 30.
Throw into an arrhythmia?
Nope, that's not it.
I quit.
Give the RSI drugs that'll up their potassium?
Nope.
Think
that's not
about
it.
what they're doing with blowing off all of that.
What is their CO2? 24? Is that 22, 24? Low. CO2 is low. Her pH is probably at or below 7. Okay, needs to be what, 735 to 745? So if her pH is super low and we're breathing fast, what can we assume? We're in an acidotic situation, right? If her CO2 increases, what keeps going down? Because CO2 is an acid, right? A potent acid, a potent vasodilator. If her CO2 goes up at all, what happens?
Her blood pressure will go down,
Her blood pressure is going to go down,
heart rate will go up.
heart rate's going to go up,
and
her
then
acidosis is going to
Go up.
Worsen.
Increase.
worsen. It's going to worsen.
Yes.
It'll go down.
The numbers will get
Right?
smaller.
So this person's already pushing 6.97. Incompatible with life starts at 6.7, 6.8. Shell got a preteen.
Izzy, you
Oh,
missed
yeah.
it.
You missed it. I said 6.7. You missed it. Come on. I gotta have somebody in here doing that stuff. I've got a preteen, so my management of the 6.7 is just doing it more in front of her and her friends.
Oh, she
and it
loves
is
it.
slowed down.
She loves it.
She loves it. Yeah. So I just do it more. It's like
Whatever.
you're such a cringy millennial, Dad. I'm like, meh, you'll have that. So if her CO2 increases, her pH is going to decrease. If her CO2 goes up, her pH goes down. If her pH goes down, the cascade of unfortunate events is going to spiral rapidly for you. What happens to pH when someone stops breathing?
Become more acidotic.
it's going to go down. CO2 is going to rise, so pH is going to go down. They always travel opposite of each other, right? In this situation. So, if we give a fun little drug called rocuronium that makes her stop breathing while she is in this state, what is going to happen? CO2 is going to spike because she's not breathing 30 times a minute anymore. What happens when our CO2 spikes? I mean a jump from low to mid-20s to 7 in no time. Because she is cranking through sodium bicarb. Sodium bicarb curve. You know, we're moving sodium bicarb, CO2 and water, exhaling it back and forth, right? We're constantly moving that. Hydrogen ions being mixed with the bicarb creates CO2 and water, right? So if we stop breathing off that CO2 that the hydrogen ions and the bicarb are binding with inside the body, CO2 spikes. pH goes down. When that happens, code. You're going to go into cardiac arrest. This is the most dangerous RSI you can do. So how do we mitigate that? Because sometimes we need to. Sometimes we have to. Sometimes we don't have a choice. Okay? So, this is the end of it. So this is something I want to hammer home because you guys are going to be faced with this. If you haven't already, you may not even known you were faced with this because we don't talk about this enough. Who likes acid base? Right. Who likes it? Who likes it? When you get deep diving into the care of these people, it is so important. Okay? Carbonic acid, CO2 and water. Sodium bicarb binds with hydrogen ions, turns into carbonic acid, turns into CO2 and water. CO2 and water. Carbonic acid. See what I mean? Goes back and forth. You interrupt this, things go awry. So this human.
Could you do sodium bicarb before intubating to help bring?
Wonderful, you should ask. I kept saying sodium bicarb. What happens? Is there like a board underneath this?
I don't think
Yes.
so. Is there?
Uh-huh.
Oh.
There's a whiteboard. Oh my God, no way. It is so slow.
Hey, it's old,
Should've done it
okay?
an hour ago.
I know, right? Oh, there's just a whiteboard underneath it.
There's some dry erase markers, I think, in that container on the file cabinet there.
Look at that. 7-year-old bowel movement, warm pupils, inhaler, in hands, la da da da. Right?
That's probably from the advanced class.
Probably. I want to. Accuracy for me is important. So I want to make sure there are people who are a lot smarter than I am who can just rattle this off their brains and it'd be fine. Okay. What's that?
Hydrogen.
Hydrogen. What's this?
Bicarb.
Bicarbonate. What makes bicarbonate in our bodies?
Kidneys.
Kidneys.
Kidneys. Okay. Kidneys release a little litmus guy. We're getting acidotic. Let's dump some bicarb. We're getting acidotic. Let's dump some bicarb. Let's get some, just keeps doing that until it runs out of bicarb. That turns into So, bicarb binds with a hydrogen ion and turns it into what? What's that? Carbonic acid. Okay? Carbonic acid is then turned into, I know you know these two. You see what we're doing here? Right? That's why it was important for me to write this formula correctly. I know the names, but I need to know the everything. So, this is our curve. All right? Hydrogen ions bind with bicarbonate to turn into carbonic acid. Carbonic acid is then exhaled as CO2 and water. Okay? So, if we increase this, what happens? This is bicarb. If we increase bicarb, what happens?
It'll increase the carbonic acid,
Which will then increase,
breathing.
The
so
CO2.
and water.
what do we know about CO2? As CO2 goes up, what goes down?
pH.
pH. So CO2 goes up, pH goes down. What are we doing when we bolus sodium bicarb without being able to adequately respire the CO2? What are we going to do to our acidotic patient? If we can't ventilate all of that CO2 off that we're creating by pushing bicarb, which binds with hydrogen ions, which creates bicarbonate acid, which then is exhaled as CO2 and water, this is getting hung up. If we can't breathe this off, this gets hung up. So then what happens to it? It goes up. So CO2 is building because we can't breathe it all off. So as that goes up, it goes down. So for about 5 minutes, your patient on a bicarb bolus is going to look better. And then all of that CO2 is going to rebound once that bicarb turns into carbonic acid, turns into CO2 and water. Because in the short term, the hydrogen ions will bind with that bicarb, and the pH will look better, and your patient will look better for a few minutes until all of that built-up carbonic acid starts to get broke down into CO2 and water. And it's fine to do that if you can ventilate all that CO2 off. Any shunts? No. Okay, pneumonias, COPDs, things like that. If you're not adequately able to get that CO2 off, bicarb's a no-no. That make sense? Clear as mud? That's the only way that I can understand it. Hydrogen ions plus bicarb equals carbonic acid. Carbonic acid equals CO2 and water, and it floats back and forth. And if you understand that, you are leaps ahead of taking care of any acidotic patient. Dan has a episode on the Heavy Lies and Helmet podcast. He did a talk at I don't know, some kind of critical care conference, it doesn't matter. That man explains it in the only way that I can understand. And if you listen to that 5 or 6 times, by the time you get done, you'll be able to read triple acid bases on your labs. But anywho, we need to know this. Okay, don't be afraid of it. It won't bite. It's not going to leap off the board and get you, I promise. I don't know if you like being bitten or not, but it's not going to do that. Being able to look at that and understand that is going to help you take care of sepsis, DKA, anything, trauma triad of death, or what's one of the, with trauma, what's one of our deadly sins, if you will? Acidosis, right? How do we prevent acidosis? Make sure they breathe, right? So it's not as scary as it seems, I promise.
How does it work in cardiac arrest then? It's that same mechanism, right?
It
I
is
was
the
wondering
same
the
thing.
same thing because
You have to
Isn't there-
ventilate that stuff off. So if you,
because I mean I guess if they're coding they weren't ventilating at all, then if they
okay,
are ventilating,
so let's look
then-
at the formula. And in cardiac arrest, we'll call this is where they're breathing, okay? So we've got a couple lung lobes right there, right? This is where breathing happens and then this happens, okay? So if this stops, what happens?
It builds up.
CO2
The
builds.
CO2 builds up.
And then our meds don't work shit.
Right, right, exactly. So it's, as long as you can breathe this stuff off, it's fine. What is better than bolusing your bicarb?
Drip.
A drip, right. Because now you're introducing this stuff slowly. I'm gonna leave that up there because we're gonna get back into it in sepsis. Now you're introducing it slowly. You're able to breathe that CO2 off. So maybe you add 100 milliequivalents to 1,000 bag and run it in at 200 an hour. You know, maybe you talk to doc and say, hey, I'm gonna put a couple amps, I'm gonna pull 100 mLs out of a liter bag, I'm gonna put a couple amps of bicarb in it, and I wanna run this at 250 an hour. Cool. You know, it's not rocket science, but you are, you wanna make sure that you do that in D5W and not normal saline. Very important. Because there's other things that affect acidosis, and one of them is sodium. If you put sodium bicarb in normal saline, you're going to scream their sodium up, right? Which is going to worsen the acidosis, right? See where it all goes. But so if you're going to do a drip, you got to do it in D5W. Clear as mud?
So we'll never do a drip. Got it.
No. It's fine. You may get to a point in
Still
your
carry
career
it.
where you feel comfortable doing it. Maybe you're doing a transfer.
We don't carry it.
If you're
I
in
was going to
the
say we
ER,
don't care. We have.
Yeah.
full
if you're in
saline,
the
that's
ER
it.
and you're doing a transfer,
Asking for a liter of
You can
D5W.
ask for, hey, can we do a bicarb drip? I really think it'll help. All right, there's people who are overwhelmed. I'm not going to discredit any work that anybody in any ER is doing anywhere. They don't have enough help. They don't get enough training, and they just don't know. Think about the things that we've talked about today that you just didn't know. Right? I didn't know this crap before I started doing this. Now I have to, because we do labs. So I gotta know this crap.
But there have been, I mean, in the past, I've taken like a bicarb drip on a transfer, and I didn't think about it being not in normal saline, so that makes
Right.
a lot of sense.
It's gotta be in D5 water. It's the slowest.
Jeopardy, the Jeopardy song.
Any questions? They're getting more interesting as I go along. You guys are asking more questions. I like it.
I think you're shooting them in a way that it's got us to thinking.
I like to talk about things in a way that I like to talk about things, because to my core, I'm just a normal street medic, and that's how I think. That's all I'm always going to think. They've forced me to learn more things now
Right.
to be able to do my job. And when I started doing it, I'm like, I had no idea. Like, you don't know. Like, what's the perfect, like when you got somebody on a ventilator, you're transferring this DKA patient. Think about this now. What CO2 on that end-tidal are you shooting for?
Their original was?
You don't know that information. You're just doing a transfer.
What kind of patient is it?
This patient, this
This patient?
DKA patient, they tubed it. They resuscitated and tubed it. And now you've got to ventilate it.
5.
No, that's dead. That's dead.
25 to 30.
That's not a bad range. Before this talk, what would you have done?
35.
35 to 45, right? That's the same way I was. That's the same way I was before someone introduced this to me. And now I'm like, oh man, a lot of stuff up. Like, I had no idea. you know, I thought I was doing fantastic. I look back, I'm like, "Whoop." That makes sense why I had to go up on pressors and I had decompensation problems. I thought, you know, so yeah.
Just, I got a question for you.
Shoot.
Talk about sodium bicarb. So, you're on Lifeline. Have you ever, where if you've gone to a flight scene and somebody's trapped, like, I worked Brown County for years.
Yeah.
You get a tree that's on them and it's been down on for a while. Do you get bicarb before you remove it?
I did that pre-hospitally for a long time.
Okay.
The science doesn't support it.
That's what I was wondering.
The science doesn't support it. Theoretically, it should help.
Yeah.
Is it probably gonna hurt anybody to give them an ampibicarb? Probably not. Have I done it? Numerous times. Numerous times.
Because I remember, I've been, what, 15 years now as a medic. I remember that being one thing that they always pushed.
Yeah.
But like, we never, it was never
And
in
you
our
probably
protocols.
haven't been hearing it as much as of late,
Yeah.
right?
Well, like, our protocols never had it.
Right.
It was just a lot of.
It was,
Yeah.
you call for an order. Hey, doc, I wanna give,
Yeah.
as we lift this thing, I wanna push this. Is it
Yeah.
gonna hurt? No. Anecdotally, that's the word I was looking for
Right.
earlier. Anecdotally, I've seen it work. I've seen events where I expected a negative outcome without it, that I gave it and didn't have a negative outcome. That is like the definition of anecdote.
Right.
Right? So anecdotally, I think it's more good than bad. Scientifically, the science doesn't support it. So take that with a grain of salt. Any other questions? We're gonna get more into acid with sepsis. That's next. So take a break.
Dan Rowell's gonna be here next Thursday.
all the little towns and all the stops. And I don't think I could take it to Santa Monica. I just don't have that kind of time. But I will go to Chicago and take it
Yeah,
down.
my cousin's oldest daughter lives out in Arizona, and
Yeah.
I've been on quite a bit of it out through there, and it's just,
I take a tent. I don't sleep in hotels. About every 5 days or 4 days, I'll go get a shower somewhere. Because the wipes just stop working after a while. It's gross. It's so gross, but I love it. All right, sepsis. How often do we see sepsis?
Every day.
more.
Every single
I was
day.
gonna say more than what we used to.
How often do people die from sepsis?
Every day.
Every single day. I think sepsis has always been here. I think that the difference now is we didn't label it. We always called it a blood infection or something like that. There's always bacteria in the blood, ridiculous. So it's what is sepsis? You mean, and I don't mean severe sepsis, just what is regular sepsis?
Systemic inflammatory response.
It's a systemic inflammatory response, an exaggerated systemic inflammatory response, okay? We're gonna get into it. Okay, it's a life-threatening inflammation in response to an infection. What does that mean? What is inflammation? What is an inflammatory response in our bodies? Swelling, right. What else? An inflammatory response doesn't always revolve around like joint swelling and something like that. Things like that. What is an inflammatory response?
It's a dump of chemicals in your bodies to fight something that is foreign or unknown.
Right.
What is uses for?
And then it gets to a certain point where the body's like, I can't do this anymore, so I'm just going to exterminate myself via my own mechanisms. Because that's what happens. The body can't fight off what's happening. So we develop vasodilation because of loss of vascular tone, right? Catecholamine dumps. Loss of catecholamine response, right? So our epi, norepi, we use so much of it up that we deplete our reserves and we're unable to give it to ourselves anymore. Heart rate goes up, blood pressure goes down, blah, 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 blah. All the things with septic shock. What type of shock is septic shock? We're going to talk about labels for a second and then we'll move on. What?
It's distributive.
It's distributive shock. Why is it distributive shock? I just said it. Loss of vascular tone, right? So it's a tank problem. It's not a pump problem. It's a tank problem. It's not a fluid problem. It's a tank problem. Distributive shock. So it's generally easy to recognize. You have some kind of infection source. You have people who are hyperthermic or hypothermic, right? Have you seen both ways in your careers? Little old ladies in a nursing home with UTI, or more often cool and not hot because they lack their bodies and their brains are not good at raising their temperature anymore. So they actually cool off due to metabolic issues. So too hot, too cold, and altered mental status, hypertension, tachypnea, all of those things. Okay? How do we screen for it? Here's a whole list of ways you can screen. What does higher sensitivity and lower specificity mean to you?
Nothing.
Right? What do you guys use to screen for sepsis?
Heart rate, blood pressure, SpO2 temperature, capnography.
Oh my gosh, that's terrible. All right, this is cute. I'm gonna have to read it to you. The black is terrible on there. Q-SOFA is a screening tool. It's quick, it's a bedside tool, has a high specificity but a low sensitivity. So it's a little easier for people to fall through the cracks, but when you do catch somebody, it's spot on, right? That's specificity versus sensitivity. So QSOFA is altered mental status, systolic blood pressure less than 100 millimeters of mercury, and respiratory rate greater than or equal to 22 breaths per minute. What does that sound like? Literally everything, right? So that's why we don't really use it. We use SIRS, okay? SIRS has a higher sensitivity rate, right? Is that right? I don't want to mess it up. Higher sensitivity rate, but lower specificity, okay? So you will catch more and be more accurate in that regard. So temperature, less than 36 or greater than 38. Freedom units, we're talking like 97 to 100, right? Heart rate, greater than 90 beats per minute. That seems a little low, right? Well, what's a normal heart rate? 60 to 100. So if we've got somebody with a heart rate on the high end of that, that's why it's boosted, okay? Respiratory rate, 20 per minute, or a PaCO2 of less than 32. Why is it less than 32?
That's about it.
Acidotic, right? Whole thing behind the whiteboard there. White blood cell count less than 4,000 or greater than 12,000. You're only going to see that if somebody's done labs at the nursing home or if you're doing a transfer. You will catch more cases using this, okay? If nothing else, let's just focus on these, right? This is where we're going to focus at. If you hit these, if you hit 2 out of 3 of those, there's like some formula that says you have a higher, it increases mortality, blah, 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 blah. But if you're seeing this stuff, it's sepsis, okay? We're septic from something, all right? When we compare the two, what it comes down to is we don't want to use QSOF alone. We want to really focus on things that are similar about them, which you can't see, right? If I were in your guys' shoe, I would take this and combine it with the systolic blood pressure of less than or equal to 100 breaths per minute, or 100 millimeters of mercury, and I would call that my combined, there it is. I would call that combined tools to make my sepsis alerts. Do you have a sepsis alert protocol with the hospital? There's no sepsis alert protocol? Okay. Maybe that's something somebody could champion, right? What do we remember about how long it takes for the hospital's gears to get moving on this stuff, right? All of that stuff. So
Once cultures come back.
right. I feel like I'm losing you. Am I losing you guys? Okay. Stay with me. I promise. We're gonna have fun. We're almost done. Okay. Some things have changed. These are our screening tools. In 2026, this year they released new guidance. An organization called Surviving Sepsis Campaign has released new guidance for us. 5 years ago, how would we have treated sepsis? We would have given enough fluids to fill Lake Monroe, right? And we would have just thrown all of the antibiotics at them. And we don't do pressors unless they're digging their own grave, right? And we withhold that because why would we give pressors when we can just give them more fluids? That's what they need. What did we find from that? What did we find from that?
Becoming more acidotic.
More acidotic, third spacing, right? Puffy legs, puffy ankles, too much fluid, developing congestion in the chest, maybe not congestive heart failure because they may not be in heart failure. We just overloaded them with fluids and the heart can't do it. Nobody's normal heart could do it. It's not necessarily in here.
we screwed them up, right? And normal saline, the bane of our existence that we keep using every single day, was what we used. So we've got these acidotic people that we're giving an acidotic fluid to them, and we think that we're making them better. But what we learned is that wasn't the best thing to do. Has anybody ever seen one of these? Have you ever heard of a Swan-Ganz catheter?
Of a swan?
Swan-Ganz
Yes.
catheter. Have you ever seen one of these terrifying devices? That is a quadruple lumen catheter that sits in the pulmonary artery that measures systolic function of the left side of the heart. And it has ports all along that all of these infuse and do different things through. And it sticks out about that far out of the person's neck, and if it moves, they'll die. No good. But that is how we measured people's fluid administration decisions. We would measure wedge pressure, which told us how hard the left side of the heart was beating, which was supposed to be our fluid resuscitation guidelines, okay? What did we find with that? We found we were screwing stuff up. So now, rather than how much fluid can I get in this human in the next 3 hours, a 30 ml per kilo bolus, right? It's a manageable, measurable approach to fluid administration to these peoples. We want to do that within the first 3 hours for hypoperfusion, not just because of septic, for hypoperfusion, all right? So we're not being dogmatic or anecdotal about what we're doing. We're taking a measured approach to improve perfusion. Balanced crystalloids, lactated ringers preferred over normal saline. We talked about that to a great extent in DKA. It is the exact same reason. It carries some nutrients that we need, some what do you call it, electrolytes. It's what plants crave. You know, I feel like that's the world we're living in now, by the way. That's a whole different topic, but it's what plants crave. So it's better, it's balanced. It is, until you get to plasma light, it is the closest thing to plasma that we can safely carry in the pre-hospital world to give to these people. It is the most like blood. So that's what we're doing now. And earlier pressors. If I were working for a place that I wanted to get norepinephrine, I would use sepsis as my reason to do that, okay? Because early pressor administration has been proven time and time again to reduce mortality in these patients, okay? We're not waiting to see what fluids do. We're giving fluids and starting pressors at the same time. We're quickly improving perfusion because as longer these people sit, and you've seen it time and time and time again, these people will sit somewhere, anywhere, and they'll get liter after liter after liter after liter of fluid. The blood pressure's not coming up, right? I know you've seen it. And the next thing you know, we're transferring them to St. Francis or Methodist or St. Vincent for dialysis. Why? Why are they now in acute kidney failure?
Too much sodium.
Can hypoperfusion for extended amount of time, anytime over 45 minutes, and you start to have kidney damage. Okay? They're dry, they've been dry, and we are screwing around with fluids, waiting on their blood pressure to come up. It's the definition of insanity. The same thing over and over, expecting different results. What is sepsis? What kind of shock is sepsis?
Distributed.
It's distributive. What's our problem? They're dry. Don't get me wrong. They're dry. But what is our problem? Our tank. But the container's way too big. And as we improve this inflammatory response with fluids and resuscitation and everything that goes along with it, what happens to the container? It shrinks back up. But we just put 6 liters of fluid into it. And I say, that seems like an exaggeration. I promise you folks, it is not an exaggeration. I've seen it. Okay? That container shrinks back up. But we dump 6 liters of fluid in. The body can only eliminate maximum 30 mLs an hour. That's perfect kidneys. 30 mLs per hour. Right? I'm sure some people can do more, but that's what we monitor. So, where's all that fluid go? It stays right here. So, the thought process is early vasoconstricting medications like vasopressin, norepinephrine is first line. Shrink that container up and fluid resuscitate appropriately and not just filling a loose container. Okay? Do you understand when I say like what I mean by like the vascular response? Like the vessels are literally just opening up and they're just as loose as they can be. It's like a floppy hot garden hose in the sun, right? Like it's no good. So that's the goal, okay? Early pressors, tighten that vasculature back up and fluid resuscitate at the same time. And we're seeing better outcomes because of that, okay? Old, aggressive loading, new, 30 ml per kilo within 3 hours. Saline, get it out. Balanced crystalloids are preferred. And that's Plasma-Lite or that is, Plasma-Lite's expensive, you're not gonna carry it. But we can carry LR, it's cheap. Makes the people dance, it's good. Patient choice, everybody. It didn't matter who you were before. If you were sepsis, everybody got 3 liters. Is there a problem with that? Who's that a problem for? Tammy, who's that a problem for?
Patient.
CHF, right? Not everybody can handle 30 mLs per kilo. Not everybody can handle 3 liters of fluid, right? So we want to take a balanced approach, not a dogmatic approach, a balanced approach with the patient's history and active disease processes in mind, okay? And that is already present kidney disease and CHF are the 2 big ones that we are gonna see in the field, okay? Vasopressor timing, old, we delayed it until after fluids. Now we want to initiate it earlier. We want to get that perfusion better so that the kidneys are perfused, so we decrease the chance for kidney injury. All right, monitoring. Before we did wildly complex static measures. Now we're doing more dynamic measures, including like monitoring with ultrasound. That's, like, we're not even doing ultrasound yet. I want to, but I won't do it. Monitoring with ultrasound and actively seeing what's going on instead of checking every now and then, okay? All right, so balanced crystalloids versus normal saline. I'm gonna read all of this because I still think it's that important, even though I've talked about it like 6 times this morning. Okay, electrolyte profile is closer to blood plasma. Reduced acidosis risk. Better renal outcomes. That's huge. Like once the kidneys are gone, the kidneys are gone. It's not like the liver. Liver, pretty good at regenerating if you stop the disease process. Kidneys, not so much. Once they get hurt, that's kind of it. Normal saline, look at the milliequivalent level of saline versus plasma of the chloride. Chloride being a negative ion, problems, binds with sodium. All right. Balanced crystalloids should be your preferred fluid for these patients. All right. Early initiating vasopressors. Levo, 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 Levo. Epi would be fine if that's what you have. Epi would be fine. It does have alpha and beta properties, but Levo is the preferred thing. Because Epi, what is Epi going to do? Inotropic, chronotropic, bigger squeeze, faster rate, right? Just a little bit of vasoconstriction. Just a little bit of constriction, right? Not much, just a little bit. Levo, what's it doing? A little bit of squeeze, a little bit of rate, bunch of vasoconstriction, right? So that's why it's your first choice. And then we want to target a MAP of 65 millimeters of mercury. What is MAP?
Mean arterial pressure
How is MAP calculated?
on the monitor.
On the monitor. I can't calculate it. There's a calculation. I have no idea what it is. Again, when my monitor does it for me, I don't waste my brain space with such things. If I need to look it up, I'll look it up. Whenever a Zoll, you guys use Zoll? Yes, I'm pretty sure you have seen Zolls.
Yep.
Whenever a Zoll or any other monitor for that matter reads a blood pressure and you get a blood pressure of a 120/80 and a MAP of like 70 something. I don't know what MAP is for that. What is that monitor doing? How did the monitor come to having a blood pressure of 120/80? You caught the unicorn. How did it do it? Do you think, raise your hand if you believe that the cardiac monitor physically read the systolic and the diastolic measures of the vasculature. Raise your hand. Raise your hand if it calculated the diastolic and systolic based off the MAP. That's what it is, okay? Your monitors don't read blood pressure. They read MAP, okay? A normal MAP is 65 millimeters of mercury. So if they've got a blood pressure of 90 systolic over 54 diastolic, but their MAP is 68, don't go dumping 3 liters of fluid on them. Their MAP's fine. Everything's getting perfused. It's cool, okay? Because it's a game of averages. It's a game of statistics and averages. So that is why we pay attention to MAP. Because MAP is what's important. MAP determines filtration in the kidneys. MAP determines cerebral perfusion pressure, not diastolic or systolic in most instances. Okay? So that's why our MAP goal is 65. I will tolerate a blood pressure in the 90s, a systolic blood pressure in the 90s if my MAP is good. I will tolerate systolic blood pressure in the high 80s if my MAP is good. Okay? And that's seeing good waveforms, that's confirming your systolic with your manual if you're that type of human. I feel like the equipment's been around long enough. It does a pretty good job. If you're not doing that, I'm not going to dump scalding water on you. But it's still good practice, you know, if you want to check your blood pressure. But our MAC goal is greater than 65 because that means the kidneys are being perfused, the gut's being perfused, things are happening, okay? Anything less than that, we really need to start talking about what we're doing. Levo, so you're not carrying it, so you're not using it much, all right? Starting dose is 5 to 10 micrograms per minute. Does Levo require a loading dose? Do you know what I mean by a loading dose?
An initial bolus.
An initial bolus. Does Levo require an initial bolus? It does not. It does not require an initial bolus. You're not giving propofol. Like if you're initiating propofol with some fentanyl, you need to give loading doses of both of those meds or you're going to see negative outcomes because you're not administering it properly. Levo, Epi, those things of that nature are not that way. Some calcium channel blockers and beta blockers drips require that, but norepinephrine is not that way. we want a targeted map of around 65. 70 is cool, 80 to 90 to 100, you know, we'll probably need to come down on our pressors, right? We want to get it on board just as soon as possible. And like I said, if I was going to use anything to my medical director to try to get levo on the trucks, it would be sepsis, because we see it every single day. We see hypotension from sepsis every single day, and the data shows we need to get levo on board. Okay? If you see levo, we would usually top out at around 30 mics per minute. Okay? Some places do weight-based. I don't like weight-based because it's harder to monitor what you're doing if you're not physically calculating in your head. An example of this would be I flew to a hospital north of Indianapolis, and we got there to a 16-year-old with a congenital heart issue that, surprise, she's 16 and now this thing's showing itself. And we walked in and the epi was running at 1.5 mics per kilo per minute. Doesn't seem like much, right? That's what the order said in the system. That order is supposed to be 0.15 mics per kilo per minute.
Oh, no.
Yes. So this child weighed 100 kilos. Math that. 1.5 mics per kilo per minute times 100 kilos. Yeah. You getting there?
Yeah,
Yeah.
that's a lot.
150 micrograms per minute of epinephrine. How much do we give in a push dose? 10? 20?
Was her heart still intact?
It was not a good outcome. I never got the final neurological outcome, but it's not a good outcome. Now, there's other extenuating factors that go along with that particular case. But it happened because somebody didn't take the time to check themselves in the system. So do what you will, but if you're going to go to a weight base on levo and epi, it's important that you calculate what you're giving to make sure you're not giving an extreme amount.
There's a lot of guardrails that failed in that,
Yeah.
because pharmacy, your pump should have guardrails, the doctor that wrote it, the nurses, there was a lot of.
You're right.
Please tell me there was a
100%
lawsuit,
right.
because,
I haven't been,
yeah,
I haven't received a tort notice yet.
yeah. that's
So,
a lot of guardrails down.
now, I would not be the one being sued in that instance.
Right.
I would be probably called for a witness.
Witness.
But I made, and that's not accidents.
Right,
As a young nurse who had no idea, should never have been on this patient, but
but still,
lack of
pharmacy should have.
resources. Not every hospital has overnight
I
pharmacy.
know.
You know, so resource limited facilities and places, you're going to see things like this happen.
Yeah.
So it's important for you to know that we want to see less than 30 on our levo. It is not out of the wheelhouse to see between 50 and 100 micrograms per minute of levo, but that needs to be limited cases for short durations. Okay? You may see higher doses than 30. The ideal thing would to be once you start to max out on a pressor, you start another pressor until that maxes, and you start another pressor. I've transported as many as 6 to 8 pressors at the same time going on.
Jeez.
ECMO, we do a lot of ECMO out of Evansville and like Elkhart, South Bend and stuff like that. You know, of the 16 drips that we're managing, 6 to 8 of them will be pressors, methylene blue, all kinds of stuff. So it becomes like this balancing act of like, don't go too high on this one or you're gonna see heart rate issues. Don't go too high on this one or you're gonna see increased left ventricular load. That's the next thing that we'll get into. If you are monitoring this person and you're going up on levo and you're seeing worsening heart rate, worsening blood pressures, and you have a known CHF patient, back off the Levofed, you need to be on Epi and Levo at the same time. As you clamp the vessels down, what are you putting load onto? Like if you've got a pump running and you have a garden hose and it's an inch diameter, and you take a hose clamp and you clamp that down to 5/8, what has to work harder?
Left ventricle.
Left ventricle, right. The pump has to work harder. So as you clamp those vessels down, if you've got an already weak heart, that heart has to work harder, and if it can't work harder and you're clamping it down more, you could see refractory hypotension from giving too much levo. So you need to go with your epi pushes too, okay? Just keep that in mind. It's okay to have more than one pressor going at the same time. But if you guys are in that situation pre-hospital, you may want to give a physician a call. So always follow your local protocols. All right, so get it on early as possible. Combining vasopressors in these patients is not only a good idea, it's common. You want to consider epi for the left ventricular load. Tailor it to your patient. Each patient is going to have different needs, okay? Vasopressin is 0.03 or 0.04 mics or units per minute. It's not really titratable, so whatever vaso does for you, that's what it does for you. That's a drug that is making a comeback. Vasopressin is. It's a great drip. It works well with levo and epi. Okay. Pre-hospital antibiotics. What do you think? Opinions?
Yes.
Yes? For sepsis?
Yes.
Yes? Who else says yes? It's okay. There's no wrong answers. Do you think pre-hospital people should be giving antibiotics pre-hospital for sepsis?
No.
You don't think so? No.
Why?
Support your opinion.
Because antibiotics are tailored to the specific type of sepsis that they have, the bacteria that's in their body. I don't think that we should be throwing just a broad spectrum antibiotic that we would give for an open, femur fracture that we would to sepsis.
Okay.
It's not going to do anything. It's not going to delay care, but
No.
it's not hindering care either, but it's not going to work.
Support your opinion.
I think it's one of those things where, because like our sepsis patients, they've been in nursing homes forever, and a lot of times they're gonna throw broad spectrums at them because cultures take days, and if you've got them here, usually the doctor will go ahead and toss a broad spectrum at it while they wait for cultures.
Both of those arguments are positively valid, and that is the discussion that's happening right now in the EMS world. Giving antibiotics will affect blood cultures. If you give your antibiotic before you pull cultures, it's going to affect the culture. EMS is notorious for drawing failed blood cultures. It's a dirty environment. We're not good at it. We're not going to be good at it. It's not going to happen.
It takes extra time.
It takes a lot of extra time. So you're doing it on the way to the hospital. You're bouncing around. Did you clean everything right? Did you start the IV right? Did you do everything? Blah, 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 blah. To make sure that they can get a good culture off of that draw. And if you didn't, and that's what they use, you've messed up that patient's care for days. Because it does take days. Unless it's a really bad culture. Like, you can get and that's always like the worst. Like, you're taking care of somebody and you've got it for your whole shift or whatever because you can't get a truck to transfer them or whatever. So 6 hours after they get there, you've sent your cultures off and you get a result back on your culture. You're like, oh no. It's like, what's that giant, the Smile Factory. That's that situation. That their infection is so bad that it cultured in less than 12 hours, it's bad or it's failed, one of the two. So there's no proven benefit one way or the other. The data is just not there yet. There's not enough people doing it. There's not enough medical directors with the confidence to say, yes, let's start doing this thing. What are the negatives to giving someone broad spectrum antibiotics when they are not septic? What does that do to us, to patients societally?
You're looking at having drug resistant.
More drug resistant bugs, right? So, you know, there's negatives not only with the individual patient because you increase their chance for, yep. You know what I'm talking about. C. diff. You know, the chance for C. diff increases when we give antibiotics. The chance for renal failure in some antibiotics is present, like Ancef. Ancef is not without risk. And we give it for open fractures, but it's not without risk. The kidneys have to metabolize that. So there's just low certainty. There's not a ton of evidence available. But I believe in the amount of time it takes us to get rid of Zofran, that we will be doing pre-hospital antibiotics for sepsis.
You think Zofran's gonna go away?
Huh?
You think Zofran's going away?
Oh, yeah.
Yeah?
Oh, for sure. Yeah, we talked about that before you got
Oh,
here.
okay.
Garbage.
It's garbage. So, and we'll talk about that after we get done. I'm not getting back on that soapbox. But yeah, I think eventually that the amount of
What
time
do you
it
think
takes.
they're gonna put in place though? Are they gonna do Finnegan?
Finnegan's dangerous for us.
I know,
because of IV. I don't think so. There's another drug out there.
Better not be compazine because so many people
I can't
react to
remember
compazine.
what places like Travis County, King County are trialing things right now.
Yeah.
So King County is Seattle, Travis County is Austin. Super, super, super high-end departments with great medical direction that are doing crazy stuff that we will see within 5 to 10 years. They're doing different stuff.
Yeah.
But anything, alcohol preps, smelling alcohol preps will have more proven effect than Zofran does. Yeah. So I think for the amount of time it takes to get rid of Zofran, we'll be seeing antibiotics pre-hospital for sepsis. With the evidence just has to support it. So the evidence against, we've talked about it. Nope, there he goes. Evidence against, there's no mortality benefit that we're proving. You increase the chance for resistance, and logistically, how can you imagine the cost of keeping Zosyn and yeah, the other big one, on a truck all the time? Crazy expensive. So, and then when not your direct leaders, but the people who manage the money for your leaders, you know, they're not going to pay for this stuff, especially in hospital-based world. That's all I've worked is hospital-based. I know how it works. We're going to do whatever is the most cost-effective way of doing it, and it's just not going to happen because there's no proven mortality benefit to support spending the money on it, right? But also, follow your protocols. Evidence supporting it. When they get to the hospital, it takes time to get them in the system, to get fluid boluses going, to get them registered. You know, doctors and nurses are overwhelmed these days in the ERs. There's not enough help. And there is a delay to definitive care. I lost myself. Some systems are having success with it, and it'll be interesting to see what their studies show. So there is evidence to support it. There is evidence for against it, and both of you proved or stated all of those points. So we'll just have to see where the industry takes us. It's the way
How
it works.
long does it take, how long do they do, like you said, out in Seattle or wherever it was at, how long does it take them before it widely comes across? What am I trying to say?
Places
They're
like
doing
King
studies,
County,
yeah.
places like King County and Austin were testing, here's an example, we're testing dual sequential defibrillation in the early to mid 20-teens. And it's still not standard of care.
Yeah.
Okay.
Okay? It takes a long time. It takes a long time. And we all know the cycle of ACLS, right? The stuff that we started with is gone for a minute, and then towards the end of your
It's
career,
back
it's
up.
all back, right? So as we learn, that's what science is. There's no one thing, that's what medicine is. There's no one thing that you say, yep, this is it, and then we do it forever, except sea colors.
Well, I look for Spanish trousers to be back for a tool.
I think that you'll see it. I think that you'll see it for, because right now there's a discussion with, that are the pelvic binders efficient. Would mask trousers be better?
Yeah.
It's actually a discussion that's happening. I'm like, oh, I cannot believe this. This is nuts. Like, I can't believe this is coming back. Let it die. Like, seriously. But that's the thing. Like, these things, they come and go. It gets studied. You know, they may be testing this stuff and they're like, this is a terrible idea. We need to not do this. We're seeing zero benefit from this. Don't. But there's some things that we just won't let die. Like sea collars. The current recommendation is get cultures ASAP and then throw broad spectrum at them. Okay, we need to be able to prove in the long term what we're giving and why we're giving it. We need to cater to the bug to prevent antibiotic resistant bacteria. Okay, structured screenings in house, patient selection, careful selection on the antibiotic use, and not just I'm pretty sure septic, boop, Ancef, boop, Zosyn. You know, we don't want to do that. Like, we can't do that. And everything, when we do things, it needs to be evidence-based, not, the word's not again. Anecdotally. Surviving Sepsis Campaign recommends caution, and they are researching it. So it is being looked at, and I think there's a chance we'll see it in the future. I mean, how wild is it to think that 10 years ago, like if you look back 10 years ago, would you have ever imagined that we would be carrying antibiotics for anything? No, right? And now we've got it for trauma. You know, so what are we going to use next? Who knows? We'll see. There's another. I don't understand why that happened. It's dumb. Sepsis EMS implementation is integral to good ongoing care at the hospital. We need to be patient advocates in recognizing sepsis, recognizing the acidosis, and treating it aggressively and appropriately for better continuity of care. Where we start, treatment bias will take over and they will treat the sepsis appropriately. If we don't treat it appropriately, that patient is going to sit there until they figure out what's going on. Okay? Doesn't matter how far away you are, doesn't matter how close the next hospital is, it doesn't matter. Take care of your patients, do good care. Case 1. Anybody ever seen her before?
UTI.
Every single shift, right? Laying in bed.
I just don't feel good. I haven't eaten for 7 days. I didn't feel like eating.
Elevated heart rate, elevated respiratory rate, fever, altered mental status. 38.9 in freedom units is like 101, 102, somewhere in there. Blood pressure, 92 over 58. MAP, let's say MAP's like 60, 62. Okay? Oh, I was right, there it is, 102. All right, we do a Q-SOFA, she's 3 out of 3. We do a SIRS, she's 3 out of 4 for temp heart rate, respiratory rate. What is this?
Sepsis.
It's sepsis. It is sepsis, okay? What's the difference in these tools on sepsis versus DKA or something else? Because you're going to take your blood sugar and it's going to be like 250. Right there. 10. Okay? That's why it's important to not just use one tool, to look at it from a holistic approach and combine them. Okay? Or sepsis. We need to make an early notification to the ED. We've got a sepsis alert we're following. that we're doing resuscitation guidelines for that, okay? ETCO2 is 26, why?
That's another,
She's acidotic. What's she doing to buffer that?
breathing fast.
She's breathing fast, right? Good job, guys. What are we gonna do for her?
Fluids.
Fluids. Fluids. Would you consider
Zofran, yes.
Zofran? Yeah, for sure. Everybody gets Zofran. We're gonna moan to the hell out of this, right? That was one that we finally let die. It's Mona. Yay! It's dead. Right? We're gonna do fluids. We're gonna do supportive care, oxygen. We're going to do. We're going to consider pretend time. You have Levo. Would you consider Levo on her with a map in the low
Yes,
60s?
yeah.
Would you smack her with 10 mics a minute?
No.
No. Would we maybe tighten her up with like 5, 2.5?
Probably give her a bump, 1 microgram of like epi.
Oh. Well, we
That's
got a
all we
heart rate
have.
of 118.
That's all we got.
I know. We're pretending.
Pretending?
Yeah. Let's
Give
look
her
at
like
this. Let's look at this objectively from just a clinical standpoint. Okay. Because maybe in the future you get it and this triggers you like, oh,
Yeah.
right?
Yeah.
So let's look at this objectively. Would we consider Levo on this patient? I would consider Levo on this patient. The fluids are going to bump the pressure up a little bit. We'll see what the map does. I would consider Levo. Maybe even mix it, hang it if we get refractory hypotension. All right.
I mean, it's not gonna hurt anything to give a small, like Taffy said, that small bump.
I don't think it's gonna hurt
You know, you
anything to
don't
give
have
a
to
bump
go-
while you're getting fluids rolling in. My guess on a patient like that, you're gonna give a 250, 500 bolus, and she's gonna tune up, and she'll be home before you get your next meal. She'll be back at the nursing home with a UTI diagnosis and some Zosyn and
She's waiting.
right. It'll take the wheelchair van longer to come and get her because they tune up so fast with the UTIs. Okay. This guy, however, 72-year-old male, sepsis plus a little CHF history. Got a systolic blood pressure in the 70s, heart rate's 112 with a map of like 54. Okay, he's altered. What are we thinking on this guy? Obviously sick, right? We know that. He's sick. He's got CHF, but also his blood pressure's low.
Pneumosepsis.
Right. So what are we going to monitor to know how aggressive we should be with this fluid?
Lung sounds.
Lung sounds, right? What's something we can do if lung sounds will not allow us to be aggressive with our...
Can we give him a nitro?
This is what we were talking about earlier.
Mm.
This is where the balance. He's got a low blood pressure. We've got a little thing. You love the shit out of it.
Epidural.
Yeah. No, not albuterol. Not albuterol.
Epi.
Epi?
We're
Oh,
gonna do epi.
yes.
Right? We're gonna increase that squeeze. Right?
Now's
This
your
is-
time.
That's
Now's
what-
your time
I
to
failed.
shine. Now's your time to shine.
Drop the ball, sorry.
Okay, we're gonna consider epi. We're gonna consider levo. We wanna tune that heart up a little bit so we can move some more fluid. We're gonna debunk. We've got what kind of time we got here? I don't wanna, A, I've gotta go to work, and B, you guys, just wanna respect you guys' time. We've got 15 minutes left, 13 minutes left, so we've got time yet. CPAP. It's an interesting topic. Let's talk about CPAP. What are we gonna do with CPAP on this guy? What's the goal? We're oxygenating well because we've got fluid on the lungs. We need to get more fluids.
Fluid off
Right.
or out of the lungs.
Does it? Does it? Okay. So a thing that I was taught that we now know as a common misconception is what we do with CPAP. Before, the thought process is we've got our alveoli, right? I'm such an artist. Right? And they're coming off the bronchioles. We've got our alveoli, you know, and we've got like, here they are, and we've got this fluid in there that's sitting, right, hanging out in the alveoli, right? That's what CHF is. We're having trouble moving. We've got low surface area. There's not a lot of oxygen exchange going on. So what do? Put them on CPAP, right? What we were taught was we push pressure in and this gets squeezed out. We're pushing that fluid out so that we have more alveoli to breathe through. What we know now is that's not exactly the case. What we are doing is taking that little shriveled up alveoli that's not breathing well, and we are making it bigger. Okay? Same amount of fluid, but now we've got way more surface area to exchange gas with. Okay? In a common CHF, then we start combining things like nitro, blah, 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 open the vascular, make the vascular space available to transport more, we diurese them, and all of that stuff, and that eventually moves the fluid off. But what we're doing just with CPAP is we're expanding that space.
If we're expanding that space and we're making it larger and thinner, are we actually helping to increase area for gas exchange if we're just really pressing air into it?
That's an excellent question. So, it comes to a point where expanding that space stops helping. And it does so by this. You've got capillaries all over the surface of this alveoli. As we compress, when it starts, that capillary is going to be nice and big. The more pressure that we add, okay, that compresses until we get to a certain point, that capillary is over compressed. And now we're not exchanging. Okay? So as the alveoli stretches and collapses the alveoli, there's a curve of where we stop being beneficial. And you'll reach that because you'll see improving oxygenation status. And then you'll cross the threshold and you'll start seeing CO2 rising and your oxygenation going back. You need to back off the pressure. Okay? So that is a thing that happens, 100%. And then we use other things to get fluid off the body. We diurese them with furosemide or whatever Lasix you want to use. And we use nitro once our blood pressure is stabilized to open those vessels up, and we force the process a little harder. But in the short term, we're not pushing fluid out, we're expanding our surface area. Okay? So, all right, cool. So we're doing that thing. Oh no!
I think it's just step on top of it.
It's gonna drop.
Now super fast.
Oh yeah, it's so slow, it didn't impact it at all. Where's your button, Tammy? There it is. All right, we got people on a chair. What's sitting next to him there?
CPAP
That's a CPAP mask.
and
We
pack
got
cigarettes.
some drugs. We got some smokes over there.
Of course.
Yeah, right? You know,
Gotta
I
have
mean, it's in a prescription bottle. It probably is. Super gross place. Got a low SpO2 saturation. Got a high respiratory rate. Got a low CO2. We already got tachycardia. We're heart blood pressure in the 70s with a map in the 50s. What do?
Fluid resuscitation,
Fluid
oxygenation,
resuscitation.
pressor.
No. Fluid resuscitation, pressors, CPAP. Would definitely think that this guy would benefit from like a 5 to 7.5 millimeters of water pressure. I think he's going to drop off after that. What are your opinions of an altered mental status with non-invasive pressure, non-invasive BiPAP or CPAP therapy.
If they're unresponsive?
Altered mental status.
Altered.
Because this guy's gonna be altered.
Yeah.
Are they holding their airway?
What's our threshold for that? Are we managing secretions? Yeah, and he's managing secretions. He spit at you when you walk in the door.
Oh.
He's so altered, he spit at you.
Green light.
Right? So even though he's altered, do you think he'd be okay to go ahead and throw some pressure on him?
Yeah.
I think so.
It
When
might
are we gonna
even
not
help.
do that?
Unresponsive.
Well,
Fully responsive.
Remember, unresponsive people can maintain their
Secretions.
secretions.
Yeah.
Right. I love that term. The first time I heard that, I'm like, oh, that's so smart. Why haven't we been using this all along? Are they maintaining their airway? Is the simplified version of that. But, you know, follow your protocols. But I think he can handle some non-invasive therapy. I think this guy is going to stay like this for a really long time. This is the second most dangerous RSI you will do. Okay? He can tolerate a little more. These guys aren't as acidotic as a DKA. They are acidotic. Don't discount it. They're not as acidotic with these vital signs as a DKA. You're going to see, since he's got respiratory issues, we don't know what that shunt is yet. Is it fluid? Is it pneumonia? What's causing his sepsis? We don't know yet. We can guess that it's either CHF with a combination of pneumonitis. We'll have to do a more balanced history to find out what that is. But this guy is going to be another one that if you make the decision to RSI this man, you better do some solid resuscitation first, or he's going to gomer on you. Okay? That's going to be aggressive pressors. You know, your push doses. Push dose pressors are awesome. Don't let me undersell the importance of push dose pressors. They've been probably one of the greatest additions to our toolbox in the last 5 to 10 years. Is push dose pressors because they're quick, they're effective, and they save people's lives when used correctly. But this guy's going to end up on a ventilator. So he may be another one that let's do a solid resuscitation on him. Let's work hard. Let's get the pressures going so when we get to the ER, they can go ahead and tube him because it's going to be the safest thing for him.
Dumb question.
No, it's not. 72.
54.
Okay. That's a good answer.
When you use CPAP and it opens up the alveoli, does that stay after the patient gets back to normal? Do the alveoli stay open?
When you drop pressure,
go
they
back
close.
down. Right, okay.
If you remove that mask within 30 seconds, those alveoli are coming back down.
Okay, that's what I
Have
figured.
you
but-
had the airway class where they bring like pig lungs in and ventilate them for you? Have you seen those classes before?
Yes, I've
Okay,
seen it.
it's like that.
Okay,
It's not like this, it's not doing that. They're not smacking closed, but you know, by 6, 7 Mississippis, you've lost recruitment.
okay.
Okay, and that's what we're doing. We're increasing recruitment. Oh, that's gone now. But we're increasing recruitment of the alveoli.
Okay.
So within 6 to 10 seconds, you're losing that recruitment. So it's
That's what I
important that you
figured,
keep
but-
that mask on.
Since you did, instead of forcing out the fluids like we've been taught,
Right. I was also taught that, and then somebody said, that's not what's happening. I'm like, oh, okay, well then tell me what's happening, because I don't understand.
yeah.
And when you think about the logic of it, it makes sense that that's what's actually going on. So balanced crystalloid versus normal saline, what are we doing here? LR versus saline? LR is. We're going to reassess after each 250 ml. I like to call those fluid challenges. It's a little sexier on your documentation. It'll keep you out of the principal's office. Instead of bolusing a CHF, did fluid challenges, right? So, and then we're going to get our MAP goals up to 65. Consider pressors. He's going to need pressors. There's no doubt about it that this guy needs something. In your world, you're going to give epi. When he gets to the hospital, he's going on levo immediately.
What about considering breathing treatments?
Well, what would be your goal of a breathing treatment?
Opening up the airways?
Do we have a bronchospastic physiology presenting to us?
No.
No. So I would say that you can do a breathing treatment. It's going to be ineffective and probably not a great use of your time. It's not wrong, you're not hurting anything, but you are gonna have other priorities that you need to hit on, especially if you're in a limited situation of amount of people that you're gonna be running does cardiac wheezing exist? Has anybody ever heard of cardiac wheezing? Where there's so much fluid on the airways that it creates a bronchospasm situation. It's not your typical COPD or asthma exacerbation. The fluid in the airways will cause the bronchioles to spasm. That is a thing that exists. So what I would look for in this person to know whether I need to be doing fluid management and bronchospasm management is there wheezing present with the fluid that you're hearing. And then we run into the conundrum, now that you're hearing wheezing and gunk, do we have CHF or pneumonia?
Are you hearing bronchi or are you hearing wheezing? Because usually those are a big difference with them.
Sometimes. I can count a handful of times that I thought what I heard was pretty clear pneumonia that ended up being cardiac wheezing with some fluid on it. I can count a handful of times that it was wrong the other way too. So sometimes we shouldn't do anything with these guys, okay? I agree with you. Most of the time the rhonchi, the singing sounds are pretty clear and you have a pneumonia situation. But sometimes, like those people that you have a tube in and they have so much pus in their lungs that you can suction it out, that sounds like CHF. I'm sorry. It's so loose and it sounds like CHF, and it is hard to tell the difference. So it's going to be a judgment call, and sometimes that judgment call is to just support the vital signs, maximize the perfusion as much as you can. They need radiography. They need imaging to know what's actually going on. If you have ultrasound, you can take a look. You're going to be able to see.
We don't even have professors.
I know, but
Come on.
maybe someday you work somewhere with ultrasound. It's in the area, so it's not that far out of the wheelhouse. So you could do ultrasound, and you'll be able to see it on ultrasound whether it's fluid or whether those airways are clear. Okay. I think I beat those all to death. Questions? Hopefully that wasn't too miserable of a morning.
It was not miserable. It was
Good.
very informative.
Good. I hope for this to be the dynamic that I do with your leadership, or if your leadership in here when we do the RSI. This is my goal, is for it to be like this. So I'm excited for you guys. I've been doing RSI my entire career, so it's nothing new for me. I'm excited for you guys to be taking that step. So, questions, comments, concerns? Anything for the good of the order? What are we doing for lunch? I can't really, I'm just making conversation.
Savings goal.
Yeah.
Yeah.
I've got to go to Les, so.
You working lunch today?
Want a little extra cash to take to a motorcycle rally with me next week. Yeah, Maggie Valley's going on next weekend.
Oh, is it?
Yeah. I'm meeting a guy who I met last year that flies for Wake Forest Baptist in North Carolina, and his vice president, which I didn't know that was happening until yesterday. I'm like, oh, is he cool? He's like, yeah, he's really cool. I'm like, okay, I'm not going to try to impress this man. Don't ask me to. I'm going to do like biker shit. So I hope he's okay with that. Don't think less of me. But I'm not at work. Yeah, I'm pretty excited.
you should be, that'd be cool.
All right, guys. Good talk. Do I need to sign any books? You've got a QR code, right? So
Yeah.
that you should carry a certificate for that?
Yeah,
Right on.
this is part of the 48-hour refresher, so. Yep. If any questions, problems, let me know. I appreciate Justin and everything he's done. We will wrap up with Dan Rao next week, same time, same channel.
Is there a day for skills sometime?
It's just all added in there.
It's,
Unless you need to do some skills, and I'll be glad to set some up.
however you get it worked out.
But other than that, Daryl and I decided sitting through this just probably was better than the skills. Unless you need them, and I will be glad to do it.
I need to get a hold of him. We haven't set a date for those, that RSI stuff yet.
For the
All right,
days
thank you.
that
You
were-
bet. Have a good day, guys. Enjoy your afternoon.
Huh? For the days that were canceled, the refreshers that were canceled, are you making those up?
That was
That's
this
today.
one,
That was this one?
Yeah.
and next week.
And, cool.
I mistakenly scheduled myself to do this and had a shift that night, which I don't care.
Oops.
I've been doing it for decades. But they have a 10-hour rule, and we're not allowed to work 10 hours before it goes.
I work for, people ask the difference between working for LIfeline, Side EMS, and IU Health, and that was one of the main things, because I started out at Bedford many moons ago.
Where?
Bedford, Lawrence
Bedford?
County, yeah. And
When
then
it was
I,
still Lawrence County?
whenever it was Bedford Regional.
Gotcha.
And then eventually I left there, and then I went back when Cammie was over it for a while. And then I left a couple of years ago. I ran into some health issues and decided I needed to give some stuff up, so. I worked over in Bryan County quite a bit
Yeah.
instead of Lawrence County at that point in time. But I really